Hello dear students. So today our topic of discussion is the treatment portion. The treatment of congestive heart failure, drug used in the congestive heart failure. Now, let me tell you sequentially which which target you have to hit. Now you know that in congestive heart failure there is a retention of fluid inside the body. Number one. Number two, there is low contraction. That means you need to remove the excess fluid from the body. Number one. You need to increase the perfusion towards the organ. That means you need to increase the contractility of the organ. You need to increase the output. Okay, so that means what are the targets you have to hit in congestive heart failure? That means the main culprit in congestive heart failure is renin, angiotensin, aldosterone axis. Okay, you need to target the sympathetic outflow. You need to target the vasculature system. That means you need to target the vasculature. Number 6, you need to target certain enzymes. Say for example, Nephrolysin. What is this? I will let you know. You need to decrease the body fluid. Decrease the total body fluid. You need to increase the cardiac output. How you increase the cardiac output? By increasing the contraction. You need to increase the perfusion. Okay? Let me take one by one. As I already told you, there are 3 ways to treat the congestive heart failure, mainly. Number 1, preload. You need to decrease the preload. Preload reducers. You need to decrease the afterload. That means afterload reducers. And you need to increase the contraction. That means you have to give the positive inotropic drugs. So one by one we are taking all these things. Now that means why to target these things? Let me make you understand why. Coming to the first, that is renin, angiotensin, aldosterone axis. You know that when there is arterioconstriction, there is low perfusion towards the kidney. So when there is low perfusion towards the kidney, there is increase in the renin secretion by the JG cell. When there is increase in the renin secretion from angiotensin from the liver get converted into AT1, and with the help of enzyme from the lungs, that is ACE, angiotensin converting enzyme, that convert into AT2. You know the AT2 here. AT1 with the help of ACE convert into AT2. You know the AT2, I told you that it is having the intense vasoconstriction activity. That means it causes venoconstriction, it causes arterioconstriction, it increases the sympathetic outflow, it increases the ADH secretion through anterior pituitary, posterior pituitary hormone, and it increases the aldosterone. Now, let me take one by one how, when AT2 increases the venoconstriction, that means it increases the venous return. When it increases the venous return, that means it increases the preload. So what I have to treat, we have to give preload reducers. That means if there is increase in the preload, there is stress on the heart. Okay. Number second is arterioconstriction. That means what arterioconstriction is going to do? It increases the total peripheral resistance. If there is increase in the total peripheral resistance, it induces the stress on the heart. Okay. Now that means you need to reduce the afterload. This is total peripheral resistance. You have to give the reducers. Sympathetic outflow. That means 82 increases the sympathetic outflow. It increases the arterioconstriction. It causes venoconstriction. It causes the venoconstriction. It increases even sympathetic flow. One of the branch of the sympathetic goes to the adrenal medulla. Adrenal medulla to secrete the aldosterone. One of the branch goes to the JG cells where the receptor renin, beta 1 receptor is also present. Through that circle, that pathway also increases the renin, and anyhow they increases the 82. Now, if sympathetic outflow is increased, there is increase in the preload. There is increase in the afterload. Okay. Now, if there is increase in the ADH secretion from the posterior pituitary, then what will happen? There is increase in the total blood volume. How? Because there is decrease in the urine output. First, let me tell you, there are two forms of edema that occur in the congestive heart failure. One is the generalized edema and another is the pulmonary edema. You know, when there is left side heart failure, when there is left side, there is pooling of the blood inside the left ventricle. When the pooling of the blood is too much, then it retrieves back through the pulmonary veins into the lungs. So that means it gets accumulated inside the lung. That means in left heart side failure, there occur the pulmonary edema. But whereas in right side heart failure, there occurs the pooling of the blood in the posterior vena cava and in superior and inferior vena cava. So there is generalized edema in case of right side heart failure and pulmonary edema in case of left side heart failure. Okay. Now let me give the drugs. You know, the first drug you give is your ACE inhibitor. ACE inhibitors. You know what ACE inhibitor will do? Simply to block disease. If ACE gets blocked, 82 will not be produced. That means no such events will occur. And no such event will occur, that's a relief to the heart. What are the ACE inhibitors? It is captopril, enalapril, lisinopril, benzopril. Okay. Number one. This is your first ACE inhibitor. You know, number one. Number second, you are going to block this 82 at the receptor level. That means you are going to block the receptor of the angiotensin 2 so that the sequel event will not occur. That means number second treatment will be ARBs, angiotensin receptor blockers. It include, I'll tell you, losartan, valsartan, candesartan. You know what they are going to do? They are simply going to inhibit the 82 receptors. Okay. ACE inhibitors, ARBs. Now coming to the inhibitors of aldosterone. You can use aldosterone antagonists. Third, aldosterone antagonists. What aldosterone antagonists will do? They are going to block this aldosterone, inhibit the aldosterone receptors. The examples for aldosterone antagonists are spironolactone, eplerenone. You know what these two will do? They aldosterone antagonist, they are doing two important things also. One is they decreases the cardiac remodeling because they decrease the fibrous tissue growth, number one, and they are the potassium sparing. Okay, now you used aldosterone antagonists. Number four, you are going to use, you use this in order to reduce the sympathetic outflow. Number second, in order to reduce the sympathetic outflow either here or here, you need to give beta blockers. Beta blockers. Say for the metoprolol, carvedon, Dilo. You know what these beta blockers will do? They will inhibit the beta receptors wherever the beta receptors are. That means they inhibit the beta receptors at the SA node, inhibits the beta receptors at. Actually, what happens if they block the beta receptor at the SA node? That means they are acting as negative chronotropic. That means they are giving actually when your heart get oxygen, that is in diastolic phase, your heart will get oxygen. But when you increase the heart rate, that means you are giving less time for ventricles to refill, less time to refill. That means you are decreasing the diastole phase. If you are decreasing the diastolic phase, that means you are decreasing the oxygen consumption by the myocardial cells. That deteriorates the failing heart. So, in order to increase the consumption of the oxygen, you need to decrease the heart rate. Okay, that means you are using this beta blocker. Okay, now there is one more drug. You know, when there is stress on the heart, ventricles, the ventricle secretes a hormone, a type of peptide. That peptide is known as brain natriuretic peptide. Say from the brain natriuretic peptide. You know what brain natriuretic peptide will do? It is going to this, let me write here BNP, brain natriuretic peptide. This brain natriuretic peptide inhibits 82 in response to the insult. So that means they releases when they find the insult because of this renin-angiotensin aldosterone axis, they are going to produce, myocardial cells are going to produce brain natriuretic peptide. This brain natriuretic peptide will do, they inhibit the 82. Okay, but in normal condition, there is one enzyme that is known as nephrolysin. Nephrolysin. It is going to block this BNP. You know, nephrolysin, if block BNP, that means they are going to block this activity. If they are going to block this activity, that means they are increasing the 82 action on the heart. So one of the treatment you can give, that means you give nephrolysin inhibitors. Nephrolysin inhibitors. You know, nephrolysin inhibitor, there is one drug that is known as scubitril. Let me check. It is Yes, sacubitril. It is SACUBITRI. Sacubitril. Okay. You know when this is nephrolysin inhibitor. It is mainly given in combination with valsartan. Valsartan. The combination of sacubitril and valsartan is Entresto. Entresto. That means their Entresto is a combination of sacubitril and valsartan. They are given for the treatment of congestive heart failure. Okay. Now, to decrease the total blood volume, where I can write this, coming here. So, in order to decrease the total blood volume, you give number 6 diuretics to reduce the edema and to decrease the fluid, total blood volume. Diuretics. In diuretics, you mainly give loop diuretics, that is furosemide, ethacrynic acid. Okay. Number 2, you can give thiazide diuretics. In thiazide diuretic, you give hydrochlorothiazide and metazolam. Okay. Now, what is the action of these loop diuretics? Simple. Loop diuretic, actually, what is this? Is your nephron. Say, for example, this is the loop. This is the distal convoluted tubule. This is your collecting duct, say, for example. You know, the loop diuretic acts on the loop. You know what is happening in that loop? Normally, around 25% of the sodium get reabsorbed from the loop of Henle with the help of sodium potassium chloride channel. So the loop diuretic block that channel, by which this 25% of the sodium is retained inside the body. When you loop diuretic block that channel, that means 25% of the sodium is going out of the body. That means you are releasing around 25% sodium. If you are losing 25%, that means you are sodium will drag along with water. Sodium will drag water along with it. Okay, number 1. Thiazide acts on the sodium chloride channel here. Here around 10% of the sodium retain inside the body with the help of sodium chloride channel. But when it acts, it inhibits that channel, sodium chloride channel. That here sodium potassium 2 chloride channel gets inhibited. Okay, I will make you understand in the diuretics also. Okay, you are using diuretic to decrease the sodium, to increase the expulsion of the sodium from the body and to increase the fluid from the body. That is diuretics. Number 6, your treatment. Now you have to increase the contraction. Number 4, to increase the contraction, mainly the drug of choice is your digitalis. You know, in digitalis there are 2, digoxin and digitoxin. Okay, digitalis is the only inotropic drug which is given orally. Other positive inotropic drugs, which intravenous positive inotropic drugs are number one. Sorry, inotropic drug. It is dopamine and dobutamine. These two are given IV and this is given orally. Okay. Now you treated, this is the treatment part of the congestive heart failure. Now in next class we are going to discuss the main portion, the main part